started. Okay, first off, we want to know who is here and where you are from. So please take a moment to introduce yourself in the chat box, noting your name, organization, and what kind of work you do in this space. For those of you who were not with us at our launch webinars back in June, the Texas Consortium for the Non-Medical Drivers of Health is a new statewide effort aimed at advancing the integration of non-medical solutions into the healthcare delivery system so that we can improve health outcomes and reduce health disparities across the state of Texas. We think the consortium is both needed and timely as there's growing momentum across the state around the integration of NMDOH into the healthcare delivery system. We're seeing health plans, providers, health systems invest in non-medical interventions on behalf of their patients and in response to a growing number of community clinics and health professionals are implementing a variety of programs to improve conditions that have a negative impact on the health of their patients. The Texas Consortium provides a dedicated space for all stakeholders to come together to share, learn, and support what is working and to build a field of practice for NMDOH in Texas. In addition to these September webinars and an in-person statewide conference we'll be hosting on December 8th, we have just launched our NMDOH Program Index to catalog programs across the state that are sponsored by health system organizations, including plans, providers, and hospital systems that target NMDOH for their patients. The index is a single repository of NMDOH programs that features abstracts of programs, as well as searchable fields including program sponsorship, drivers of health, target populations, health conditions, locations by county, and evaluation status. Our goal is that this index may serve as a resource for anyone working in this space to know what is happening, what's working, and with what costs and benefits. But the program index will be as robust as we make it, so I'd like to invite you to carve out time this week to view the program index and connect with me to add an abstract about the NMDOH program you're implementing. The link to the NMDOH program index is in the chat, so please click this link, bookmark it, and when you're ready, reach out to me at jk90@rice.edu. We'll share that afterwards, and we'll get your program submitted. Now let's get to our session today. I'm excited to introduce our Food and Nutrition Workgroup leader, Dr. Shreela Sharma, who is the founding director of the Center for Health Equity, who has arranged a great presentation today titled Food as Medicine Programs and Health Systems. Where should we begin? They will make their presentation and we'll have time at the end for Q&A. Of course, feel free to put your questions and comments in the chat throughout the presentation, and we'll make sure we address these at that time. Now, I'm going to turn the meeting over to Dr. Sharma, who will get us started on our conversation today.
Thanks so much, Jackie, and good afternoon, everyone. Well, I should say good morning to some of you who are in Washington and joining us. And welcome to our webinar where together we'll learn about where do we begin in implementing food as medicine programs in health systems. As Jackie warmly introduced me, I'm professor of epidemiology.
It's not working. I tried to change it. Go to your block. Where is it? This one? No, this one.
I think maybe some, is there? Okay. Well, I'll start again. I'm Shreela Sharma. I'm professor of epidemiology and director of Center for Health Equity at the University of Texas School of Public Health in Houston. I also serve as chair of the Food Affinity Group for the Texas Consortium for Non-Medical Drivers of Health. As it relates to food as medicine, my work and that of many of our team members at the Center for Health Equity is to lend expertise on design, implementation, and evaluation of food as medicine interventions, such as food prescription programs, medically tailored meals, medically tailored groceries in real-world settings. We bring together partners across health systems, food systems to implement these programs and build the evidence base to understand their effectiveness and impact. But what's really key in this pathway, what we've learned is that it really takes a village to come together. And so I'm very excited that we're having this conversation today to learn from our wonderful speakers on where do we really begin in thinking about these types of programs and interventions in our health systems. So to start off, we're joined today first by William Lyons. William Lyons serves as Senior Program Manager, Social Determinants of Health at Legacy Community Health since January 2019. He's a licensed social worker and supervisor with over a decade of experience across fields, including case management, clinical mental health services, community organizing, financial coaching, and nonprofit management. His specific expertise includes trauma-informed care, motivational interviewing, and critical time intervention. In his current role at Legacy, he primarily supports the professional development of student interns as emerging healthcare professionals across disciplines. He serves on several work groups such as Community Voice with the Health Equity Collective, Accountable Communities of Health of Greater North Side, and Coalition for Environment, Equity, and Resilience. In addition, he is a therapist providing services to youth 12 to 17 years individually and a therapy group for queer youth experiencing anxiety, depression, and gender dysphoria. I've personally had the pleasure of working with William as a member of the steering committee of the Health Equity Collective, which is a systems coalition in the Greater Houston region. Welcome, William. Our second speaker is we have a duo from UT Health staff. We have Dr. Sandy McKay, who's a general pediatrician with Children's Memorial. Can you all still hear me? Okay. I don't know what happened. Sorry about that. She's a general pediatrician with Children's Memorial Hermann Hospital, and she's the director of population health and advocacy for the Department of Pediatrics and principal investigator for the Injury-Free Coalition for Kids Houston site. She's also a non-resident fellow at Rice University's Baker Institute for Public Policy. She's joined by her colleague, Dr. Prajatka Yeragi, who's an assistant professor of pediatrics at McGovern Medical School at UT Health Houston. She's also the director of the Pediatric Resident Leadership Track on Advocacy and co-chair of Child Nutrition and Food Insecurity and Obesity Prevention Work Group of the Population Health Initiative. And she's currently leading the Produce Prescription Program at UT Physicians, which you'll hear about shortly. And last but not least, we are joined by Usha Kollipara, who is a clinical process improvement professional with a background in clinical nutrition and operations management. She's a registered dietitian and certified Lean Six Sigma Master Black Belt and has been in healthcare for over 20 years in various capacities. In her current position with Southwestern Health Resources, Usha is a network Lean Six Sigma Black Belt, leading large systems design, redesign initiatives that improve care delivery in Southwestern Health Resources network. As part of the Care Transformation and Innovation Department, Usha's focus has primarily been on facilitating redesign of care management and disease management programs using predictive analytics and data-driven solutions to improve clinical outcomes and reducing cost of care. As you can see, we have an incredible lineup. We are very excited to have this conversation. So with that, I will pass it to William to kick us off.
Thank you for the great introduction, Dr. Sharma. So before I get started with my slide deck, I wanted to just see who's in the room. So if you are a healthcare agency or clinic and you're looking to start a food as medicine program within the next 6 months or so, if you could put a 1 in the chat. So if you're a healthcare organization looking to start a food as medicine program in the next 6 months, if you could put a 1 in the chat. If you are looking to start, if you already have a food as medicine program, so you have a food prescription program or medically tailored meals, if you could put a 2 in the chat, that'd be helpful. Lots of 2s. And then if you are a CBO, so you are a food pantry or a food bank, and you are working to provide food or looking to provide food for some of these programs, you could put a 3 in the chat. And then last but not least, if you are a research institution, so you are a researcher, you are work with a large university or college, or you are a not-for-profit research institution, you could put a 4 in the chat. So you're looking to help evaluate some type of food as medicine program, food prescription program. Lots of 4s. Okay, great. Thank you. So I like doing this at the beginning so we know who's in the room and so we know how to tailor our conversation. So it seems like most people have established the program, but maybe we're looking for a little bit of refinement, seeing how other people are doing, or maybe we're trying to expand and grow. But I'm hoping that at the end of the presentation, we're able to support everyone where they're at. And I don't see my slides. Are they visible? Oh, there they go. Okay, cool. Cool. So I work at Legacy Community Health. We're based in the Houston-Harris County area. We also have clinics in the Jefferson County area in Beaumont. And what I'd like to start it off with is our story. So recognizing about 40 years ago, we were providing mostly HIV care during the HIV epidemic. And so I like centering us here because we have experienced so much growth. And so sometimes people see us as we've grown today, but not necessarily knowing how we got started. And so what I like about how we got started, it really helps give us perspective on being sure that when we're talking about holistic care, that we're including all populations within that. For our food prescription program, it's been really interesting and surprising to see how many people who typically would be targeted for maybe infectious disease related interventions and services are accessing primary care services to be healthier overall. Next slide. So we started as one little clinic in the Montrose area back in the 1980s. And so we've just experienced so much growth over the last 40 plus years. Next slide. So today we have about 58 plus clinics. We also have some school-based clinics that help us reach that 58. We're currently tied for the largest school-based system in the United States, and we might beat out our competitor in Louisiana. We're scheduled to build 2 more school-based clinics this year or next year. So we're looking forward to that growth. We serve a large patient population here in the Southeast Houston, Texas area, and we're striving to provide the best care we can to as many people as possible. Next slide. So our patient population here at Legacy are those who typically we would consider underinsured or who don't have insurance. And so I like sharing that just because I'm not sure of other clinic spaces in the mix, but when you think about your food as medicine program, being really mindful about the patient population you serve. So being mindful about what your needs are for your population, how they access care, how they access information, the age range, so recognizing how you might approach someone who's in the early 20s might be very different than a senior. So really being mindful about your patient population. So I want to just level set, this is Legacy as we look by numbers. Next slide. So we are a federally qualified health center. So we offer a variety of primary care services. So as you think about your food as medicine program, or whether you're starting to start one or you already have an established one, being mindful about what service lines are you trying to target to implement your intervention. So for our program, we focus on adult medicine, family medicine, and pediatrics and OB. Yet people could choose to do behavioral health. They could choose to do senior care. You could think about pharmacy-related intervention. So really thinking about what is your core base of services. Next slide. So when we were thinking about our program, we really wanted to align it with our kind of philosophy and how our pillars of how we think about care. So at Legacy, we really strive for high quality care. And so making sure as we were introducing a food prescription program that we were aligning, this helps us provide more high quality care. And not just doing maybe the bare minimum. So going above and beyond to be sure we're making sure patients have positive health outcomes. We strive for prevention and early detection, and we really try to engage not only our providers, but also our patient population. So we do routine feedback from our patients about their care that day, and really striving to be sure patients are getting the best quality experience possible. And one thing that we're emerging in is doing that care coordination and close loop referrals. And so that's what my team within Health Connect, our social determinants of health program, that's what we are looking to grow and develop. Next slide. So when we got started, we first identified leaders within our agency that wanted to start a food as medicine program. So at the time, our chief medical officer was really interested in the program. We had a passionate social worker, my former supervisor, who was really passionate about how to grow this. We had collaborators within Houston Food Bank who were looking to grow in this era. So a lot of leaders came together, both inside our organization and outside of our organization, to help us develop our program. We identified subject matter experts, so people who were already familiar with the process and the procedure of how to implement one. So it wasn't a, people looking at instructions on a piece of paper, but really people who were already starting and engaging in this work to kind of come together. And then we had to craft a vision for our program. So recognizing that we had to decide where we're headed and what was the ideal first step, and hope for that we would be able to demonstrate success to kind of build upon. One thing I would say for people who are looking to start or grow their program is definitely continuing to engage with your stakeholders and your decision makers, being sure they ask questions and review research, and set realistic expectations. So again, one thing that you might hear from us today is how successful we've been, but in the beginning, there were a lot of low referrals. There were a lot of times where we weren't experiencing success. So really thinking about as you start or you're trying to scale up, set up realistic expectations for your program. And then lastly, think about barriers. So one barrier that we experience often was around language. So recognizing that we had to be sure that as our patient population was engaging with the materials, that they understood what that meant. So we kept kept the information simple and straightforward. And then thinking about best practice for equity. And I just got the notification, I have 3 minutes left. Next slide. So the first thing I would say to do would be to start with your food insecurity screening. So being sure that you're routinely screening your patients for food insecurity, because that's where you're going to hopefully target your intervention. Next slide. So one thing I would say about this slide, to be respectful of time, is really for us, how we got started is we identified one clinic that had all the right stuff. So it had site leadership engagement, it had provider champions, and the patient population was high but not overwhelming. So when you think about improving or building a program, recognizing if people are in a high traffic clinic, trying to embed something new might be a challenge. Next slide. So this is our workflow. So we use student volunteers and medical assistants to screen our patients. And then they are providing the information about the food prescription program to the patient, who then engages with the provider prior or during their visit. the provider identifies if this person meets criteria for the program based off some biometrics that we have listed here. And then they send the patient back out to the health advocate, our student volunteers, our AmeriCorps members for enrollment. And so once we complete enrollment, we track that patient over time to be sure that they're accessing their food prescription, and then being sure they're scheduling a follow-up visit with the provider to determine if they're being successful with meeting either a reduction or stabilization in their biometrics. Next slide. So from this slide, I would say definitely one of the key things I would encourage people to be mindful of is develop trusted partnerships, and definitely develop your goals and objectives. So one thing that we had to be mindful of was being sure that when referrals came in to the provider, that they were associated with a Z code or some type of non-medical driver designation, so we could track that. Value-based care is something that we've been really mindful of as it comes down the pipeline. And so really thinking about what would a managed care organization like to see as far as documentation within the chart. Next slide. And with our collaboration with the Houston Food Bank, we were able to see how our data looked. So we shared our data with the Houston Food Bank, who shared it with UT Health, who evaluated it, with other people who had implemented a food prescription program in the Houston-Harris County area. And what we see is significant improvement or decrease in people's A1C and people's blood pressure. Next slide. And as we move forward, we see that the more often that they engage in utilizing their food prescription, increase the success that they experience around their A1C over time. Next slide. And then intensity matters. So recognizing that we want to show that as patients continue to engage, that they will continue to experience improvement to their health. But I think it's also being mindful of using the patient's voice. So where we know what looks like medically, what is the patient's bottom line? Are they looking to lose weight? Are they looking to be happier? Are they looking to be more active? So really thinking about what the patient considers important as you think about your food prescription program. Next slide. Yeah, and that's it. So this is my contact information. So I know I went really quick. So if you have additional questions, feel free to reach out to me, and I turn it over to the next presenter.
Hi, good afternoon. I'm Dr. McKay. I'm here with my colleague, Dr. Yeragi, and we are here with UT Health Houston talking about our produce prescription program. Next slide. So when we look at our UT Health Population Health Initiative, what we did was we took this really concerted effort to leverage and create infrastructure support to develop our initiative. And what we did with this was we convened in 2021 a cohort of faculty and staff with leads from not only the Department of Pediatrics, but also the School of Public Health and Health Technology Informatics, as well as the School of Nursing and Bioinformatics, along with graduate research students and medical students, to really look at the broader picture of how do we help kids be healthier here in the greater Houston area. And just had a lot of really passionate people engage and prioritize a variety of different areas that we felt were things that we could close the gap on. And we convened an internal advisory board and just started looking at where we could make a difference. And this developed a scaffolding, getting buy-in and support from all different levels within the department, not only within our department chair, but also from key stakeholders within the system itself, so that we could ensure success. And over these last few years, we've been able to not only get a cadre of support from our faculty, but also go through grant processes and secure grant funding in order to continue to be successful, not only with grant awardees, but also in scholarly products. Next slide. And then I'll let Dr. Yeragi, because she's the one who's leading our produce prescription program, talk about how the prescription program has been one of the key features of our process. Good afternoon, everyone. This is Prajatka Yeragi. As we know, the prevalence of obesity is increasing in kids and adolescents in United States as well as in Texas. So over years, we as pediatricians have been counseling parents and patients about healthy eating, changes in their lifestyle, which include decreasing sedentary lifestyle and also physical activity. But even then, we have been seeing a rise. So what can we do for that? One of the challenges is to develop healthy eating habits in kids, and the other challenge is to make sure the kids have access to good food. So that's when I heard about Brighter Bites, and I've been counseling every parent and patients about Brighter Bites and to utilize the website, which has great recipes and tools. But what can we do more? And that's when I came across, I met Dr. Shreela Sharma, who is a professor of epidemiology of UT at UT School of Public Health, and also a co-founder of Brighter Bites. And that's how developed this idea of produce prescription at UT clinics. So produce prescriptions, as we know, is gaining traction in the United States, and it has shown to cause a great impact on changes in kids' behaviors and dietary intakes. But however, there are limited studies about produce prescriptions in pediatric population. Next slide. So we came up with UT physicians and Brighter Bites, a collaboration of these two teams to develop our project. So this is a unique project wherein first time Brighter Bites has collaborated with physicians to check the impact of produce prescriptions on a child's health and their dietary changes. So our study is kind of a randomized controlled trial which is being conducted at UT PB Pediatrics Primary Care Clinic as well as UT P Greens Clinic. So our trial, actually this study basically is evaluating the effectiveness of two different produce prescription strategies in the form of produce box and produce vouchers to check whether it improves obesity related outcomes and dietary behaviors among kids between 5 to 12 years of age. Next slide. So this is our project schematic. So as I said, it's being conducted at two clinics. We have enrolled 150 patients so far who we screened our kids depending upon eligibility criteria, and then this 150 kids were then randomized into three different arms. The first arm, the 50 patients out of 150 received produce boxes via DoorDash, which was delivered to them. The second arm received produce vouchers. The first and second arm, in addition to produce boxes and produce vouchers, they also received nutrition education through Brighter Bites app. And the third arm, 50 patients out of 150 were the control group, which received regular nutrition counseling and lifestyle changes. Next slide. So our eligibility criteria was we enrolled patients from UT Greens and UT PB, kids between ages of 5 to 12 years whose BMI were more than 85 percentile, were living in a radius of 10 miles of a Brighter Bites school and were Medicaid eligible. One of the other eligibility criteria was also parents were able to read and write in English or Spanish for our surveys. We excluded patients or family members who were currently participating in Brighter Bites, as well as those who were attending a school that offered Brighter Bites programming. Next slide. So as I mentioned, our interventions were produce boxes, which were delivered via DoorDash every 2 weeks, so total of 16 deliveries. 50 of our 150 recruited patients received fresh produce, the produce cards, which was a voucher of $25. They received every 2 weeks, so total of 16 reloads, and they were able to use this voucher to get produce fruits and vegetables only from the authorized retailers, which are given mentioned here. And both these groups received a nutrition education in the form of handbook and Brighter Bites app, which is a great tool to utilize this produce in a unique way so that it's palatable, because sometimes parents don't know how to use the produce, and that's how it's never introduced to kids. Next slide. So some of the metrics that we gathered are we did a pre and post survey. Prior to intervention, we collected surveys to check for dietary intake, the behaviors and patterns, and also a post survey after the intervention to check the impact of our intervention on their dietary habits. We also measured health outcomes in terms of obesity labs, which include liver enzymes, check for pre-diabetes, as well as the BMI, blood pressure, and liver function test. We also did post intervention. We are going to check for parent satisfaction of our program to make changes in our program if they feel there's some improvements need to be made. Next slide. So we have some interesting baseline data so far. We recruited kids from 5 to 12 years, and the average age of recruitment was 9 years, with 51% being males. We also identified 37% as Hispanic and 46% as Black. We also have completed some pre-surveys, about 124, which is interesting, out of the 150 recruited, and these are some of the demographics that we have. Next slide. So this slide mentions, shows you the percentage. So we collected baseline labs prior to the intervention of produce boxes, vouchers, and nutrition education. And this slide shows us a striking impact of obesity on a kid's health, which includes, which as you see, these are the labs which we had drawn prior to our intervention. And it shows the impact of obesity with higher kids having higher cholesterol, triglycerides, elevated liver enzymes, and being even pre-diabetic, which was 7%, which is quite striking, and how obesity and overweight has impacted our kids so far. Next slide. So our future plans, I want to go over. So as we get more metrics, more data into it, we are definitely looking forward and hopeful to have a positive impact on our kids' behaviors. We are likely to expand our program to a larger randomized controlled trial to include more clinics and to have more kids involved in this program. Next slide. Our team, these are our team members, so it would not have been possible. Each and every member has contributed significantly to our program. It was impossible without their efforts. It was a partnership between Brighter Bites, UT physicians, UT School of Public Health, and McGowan Medical School students who played an active role and contributed to this study. Thank you so much, everyone.
Absolutely. And I will also say that the work here that's been done would not have been even possible without having that framework and that scaffolding in place with the support from leadership from above in order to even implement a project at this scale and level at this point. And we look forward to seeing all the post results as we continue to get the kids back into the clinic to see the impact of this program, so we can hopefully move the needle on some of those metrics. But thank you for your time, and we'll turn the show over to the next presenter.
Hello, can you hear me?
Yes.
Okay. Hello, everyone. I'll try to make up for some of the time here, but I am Usha Kollipara. I'm from Southwestern Health Resources, and we have been focusing mostly on medically tailored meals, and that's what I want to spend a little bit more time on in my presentation. And if you go to the next slide, please. I want to kind of go over a little bit about who we are, why food insecurity is important to us before, and then talk a little bit about what's included in our food insecurity program. Kind of focus more on what's included in that program as well. So if you go into the next slide. Southwestern Health Resources is a population health company, and we are a population health arm of UT Southwestern Texas Health Resources. With that, we have about 5,000 physicians in our network, and we are attributed about 700,000 members with various value-based care contracts that we work with. And our goal really is to improve the quality of care and improve our clinical outcomes. With that, we look at various programs and services, and we look at designing and redesigning programs that help with, really proactively engaging with our members and our providers to see how we can improve clinical outcomes. One of the things we've been looking at since last couple of years is using predictive analytics to really identify members that are high risk for unplanned hospital events, ED visits, and disease progression. Our care management program includes multidisciplinary team, not only nurse case managers, but we have community health workers, dietitians, and social workers. So their focus has been really to look at not only members with complex needs, but also the rising risk. So with that, food insecurity has been a focus for us for some time. And a year ago, we did get into the ACO REACH contract with CMS, and with that, health equity, food insecurity, transportation barriers, these became a higher focus for us. Next slide, please. Like I said, I could skip the slide, but it's very clear to everyone on the call that food insecurity has a negative impact on clinical outcomes. And there's been more and more evidence that if launching interventions to improve that helps improve diabetes control, blood pressure control, and even ED visits, reduce ED visits and inpatient visits. So obviously it is an intervention that is worth pursuing and initiating and scaling if you're already working on that. Next slide, please. Medically tailored meals. So the evidence behind medically tailored meals is becoming very, very clear. What I listed here, if you could, I don't know if you could increase that, is the work done by Sept and his team. Yes, thank you. What has been shown is that ED visits and inpatient visits are higher among members with food insecurity. And then they were also able to show by providing medically tailored meals, they were able to reduce that impact. And in the members that were screened positive for food insecurity, supporting them with medically tailored meals have shown a significant reduction in ED visits and inpatient admissions, 52% reduction in inpatient ED, 70% reduction in ED, and 52% reduction in inpatient admissions. That's pretty strong if you look at it. And clinically, it makes sense that members that have chronic conditions like diabetes, heart failure, hypertension, they need their therapeutic diet, the diet that they need to follow on makes a difference in controlling and improving their condition, and supporting them with a period of time with the medically tailored meals and helping them to stabilize and get some sustainable options to help with food insecurity seem to be an intervention that's worth pursuing. So for us, food insecurity is a strategic initiative as part of our ACO REACH contract. And we started looking at medically tailored meals about a year ago. Next slide, please. So what I have here is a programmatic Gantt chart. We started looking at this about a year ago, like I said. Our Chief Medical Officer at the time, Dr. Jason Fish, and our Vice President of Care Transformation and Innovation, Jackie Mutz, it has been their vision that to improve health equity, food insecurity, and transportation are two big drivers that we needed to focus on. So as you can see, and I hope you can see some of the details in here, we've not only worked on with our team, but we've taken in a strong look at our marketing strategy, our partnerships with the community. And then we've also looked at our metrics, our staff training, and even our own data to see what we could do and how far we could go. Next slide. So a little bit about our partnership with the food banks. We have two strong and collaborative food banks in our Metroplex. The North Texas Food Bank supports around 13 counties, and the Tarrant Area Food Bank supports the Tarrant area. In the last year or so, we've been building strong partnerships with them. We not only utilize their classes and the produce box services that they provide, but we've also been able to share data. We built what's called a healthcare partnership, where they send home delivered produce boxes to members that are homebound, and our CHWs and dietitians are able to work with their team directly. And it has evolved over the year, and it has been very helpful in meeting our members' needs. Next slide, please. So the food insecurity screening tool is what we use right now in all our care management programs. So whether the member is referred to us through a consultative referral, or we identify them in our complex care management program or disease management programs, we across the board, we do the food insecurity screening. And one of the food banks have helped do the training for our members on trying to get a better understanding on how to ask the question, how to get the information, how to translate that to how we can help the members. Next slide, please. So a little bit about the medically tailored meals. Like I said, it has been a strategic initiative for us to address food insecurity. And with that, medically tailored meals is our next step towards getting to the members that need that. So the two key things to remember are target selection, as in who are the members that actually need this, and how long can you provide that? And because there is a cost associated with that. And then who's your vendor? Vendor partnership makes a huge difference. So our dietitians and our program managers, we've done a comprehensive search on the vendors that are available out there, the services that they provide, contractual requirements. Some of them require a PMPM, and some of them will be able to work with you the unit cost. There may be some hidden requirements with using a data sharing that becomes a long-term, lifting that up as a program takes a long time. And then the menus. The key thing is most vendors do provide menus that meet therapeutic diets, but it gets complicated as your patients have more than one condition. The members that have diabetes also have hypertension, may also have CKD. So it's where do you draw the line? So these were all the things that went into consideration. And another big one is taste testing the menus. If you want your member or your patient to eat that, you want to know what you're sending. So that went into, we went into great detail into looking into taste testing, talking to the vendors that we were going to engage with, and then looking at the nutritional values. We've asked for the menus, and we've looked at the nutritional content. We've compared that to what we would, national guidelines. Something small but significant to remember is how frequently do you want and how many meals do you want to send to your member? Is it 2 meals a day? Is it 3 meals a day? Is it 7 days a week? How frequently do you want the delivery to be? Is it 1 week or 2 weeks? If you feel like 2 weeks is a lot, you need to think about 1 week. It might cost you more. Things like that went into our consideration for the vendor. Next slide, please. This is an objective tool that our dietitians have put together to do a taste testing, an objective evaluation, and not surprisingly, this carried a lot of weight in our rating as to which vendor we were going to go with. They not only asked for a shipment that they received at home, and to look at the packaging, to look at the boxes, to look at how how they received the meal, and following the instructions and reheating instructions and tasting it. So there's a lot that went into which vendor and what service we were going to use. Next slide, please. So we are currently partnered with Roots Food Group. They provide the medically tailored meals to our members. And one of the big considerations for us to choose the current vendor is Roots has what's called a nutritional guardrails. So their menus meet, they have a 4-week menu, but each and every item meets the macro and micronutrient requirements. So for most of the diets, like sodium, potassium, carbohydrates, protein, things like that. And then, so that way they meet for a majority of the common diets that you see. So in other words, your dietitian and your community health worker do not have to worry about what condition your member may have, because these meals meet more than one condition, almost all conditions that you could probably run into. And that was a big consideration for us, and they taste good as well. And Roots currently is working with us. Our preference was to send meals once a week shipment. because we feel like our members may not have enough space in their freezer. So they're working with us on that as well. So being able to work with a vendor that customizes for your need is really important. Next slide, please. So a high-level workflow. So our program now has been live, and we've launched 3 months ago. Really, it's a brand new program. Our pilot started in June, and the workflow really is that we identify members that are at high risk for having an unplanned hospital admission in the next 6 months. So like I said, we use predictive analytics to identify who these members are. And we have a way to run a list using our dashboard. And in that list, we've targeted members that live in low socioeconomic areas. And our community health workers do outreach calls to these members and do a food insecurity screening. For those members that screen positive, they go ahead and engage them with setting up with community benefits like SNAP applications, produce boxes, mobile pantries, things that they routinely do, but they also refer the member to the registered dietitian who will then do an assessment, a comprehensive assessment, and get them started on a medically tailored meal program. We are currently focusing that for 12 weeks. Typically our programs are around 3 months long. That's how long we engage with our members. So we are during this time, our goal is to do what the member needs as far as education, getting them to be self-sustainable in planning their meals and things. So 12 weeks is what we are thinking that we would do right now, and then during the time try to get them to see what we could do to help. Go to the next slide, please. Apart from the meals, and other things that we've done is to create a public-facing web page with links to the community resources, like the links that our food banks may have, the cooking demonstrations, the grocery shopping tools, the recipes, and things like that. And this is public-facing. It's available to all our members or providers, and it's really generally open to everyone. Next slide, please. Along with that, what we did is created a postcard that we mailed to our members. So it kind of shows them that it shows the link to this webpage. It also has our email and phone number if they want to call us with questions or if they have a need that they want to talk to us. So this card is just a picture of the card that we mailed to them. And this is right now we are working with our providers to get this to them too, so they're aware of that as well. Next slide, please. So metrics for success, we want to look at clinical outcomes and reduction in utilization as ED and hospital admits. We want to look at A1C, blood pressure improvement. We want to compare 6 months and 1 year before and after. Like I said, we have about 12 members that engaged right now, but we hope to kind of look at the outcomes once we reach 100 members. And again, look at whether it made a difference, but compare with evidence and where we could do better. Next slide. That's it. So our pilot was launched in June, and we finished our pilot in August, and we expanded across the network. As we are expanding, we are working with our staff to retrain, remove barriers, things like that. We are sharing our member success stories across the network with our providers, and also working on what we call it as a graduation plan. What it is getting our members to be a sustainable plan. It's something that it's very individualized to their situation. So we want to be able to get them to say, yes, I think I have some things that I can work with. So that's where we are. Like I said, we are about 3 months into this, and we hope to learn. Thank you. Thanks for your time, and take any questions.
Thank you so much, Usha and Doctors McKay and Yeragi, William. This is absolutely fantastic. And I am also seeing the conversation and connections that are happening in chat. Feel free to, the whole premise of these webinars are to create an opportunities for everybody to learn and also to network with each other on what is going on. So really great presentations. If you have questions, you can unmute yourself. There is one question that I think it's for Dr. McKay and Dr. Yeragi from Carla Granada. Did participants get to choose which form of food resource they could receive? So gift card, the produce vouchers versus food box delivery, or did they get both? And did you see a difference in which participants found most helpful?
Great question. So participants were not able to choose where they would go into, whether they are going to get produce vouchers versus cards. It's a randomized controlled trial, so it's kind of blinded. Neither we know nor like none of us are aware about where they were randomized. So that was not an option basically. They were just randomized into either each of these arms, whether boxes versus card versus just nutrition education and regular counseling in clinic. To answer your second part of the question, so did we see a difference in the participants who received gift card versus the card vouchers versus food delivery boxes delivered to them? We don't have confirmed numbers yet, but definitely with food boxes were delivered to them every 2 weekly. There was no problem encountered in that type of intervention. Regarding food, the voucher cards, in the beginning we had a challenge in parents kind of redeeming those vouchers, but then later on, like talking to them, making sure they were able to do that. There were no other challenges that they were encountering to get that redeemed at the retailers. I think we were able to overcome that problem as well. I hope I was able to answer, and Dr. McKay, if you want to add anything to it.
No, I think as that data comes in, we're going to learn more about like the parent preferences between those two. And certainly that'll springboard us into further studies, kind of doing some comparisons between which, was more preferred between patients as well. And I think it kind of gets us down into that whole idea of which ones do people prefer. Do they want to go to the store and pick out their own food, or do they want to have something delivered to them and take that concern out of, do I know even what I'm having to pick out? Versus, do I want to have control over my own destiny? And that's going to be the magic question here that our study hopes to answer.
Yeah, thank you so much. And William, I know you put this in the chat, but would you mind sharing a little bit about your model in that regard, whether patients, what is their experience and what have you learned?
Yeah, I think this question is from Bianca. So what I would say to get started is we partnered with some of the local universities and colleges, and many of these students need some type of volunteer experience or need to boost up their resume for additional schooling. They might be looking for a master's program, medical program, and so they're looking to do volunteer work. So reach out to those local universities to see if they might be willing to volunteer with your institution. We developed our own screening tool, yet there's plenty of other ones that are established. So Prepare is the one that we'll be using. We're switching to a new EMR called Epic soon, like go live is in like less than 2 weeks. So that we're excited, yet also brain fog too. I would also say you also might look to your local food bank. So I'm not sure where you're coming from, but your local food bank might already have a program that they are looking to implement or grow. And so they might already have a program template for you to just take on and adjust to your clinic.
Great. Well, I have a quick question from Klaus, and it's probably our last question. So if each of you can just give a quick answer to that, and we'll start with Usha. Was it easy for, in terms of integrating delivery into the health system, right? How was it easy for them to get to champion the program with the patients? Do you have any thoughts on that?
I want to say, I think it was a welcome addition. Our situation is slightly different that we support the providers, the clinics. So it was a welcome addition to them, because a lot of times when the providers have a member that may have a need, they may not know exactly what to do. You have a patient in front of you that have these barriers and they don't really know what to do. So one particular clinic we work with, we created a customized list of services that are available in their area. So from that aspect, I think it's something that clinics and providers welcome, this kind of support.
Yeah. What about y'all at UT Physicians, Doctors McKay and Yeragi?
So with our program, definitely patients were quite receptive to our program. Parents were kind of wanting to participate in this program. So that was not a problem from patient side. Definitely when you incorporate such a program, that too in a clinical setting, there are challenges to implement it, making sure the clinic flow is not disturbed at the same time. But it was a team effort, as I said before. Our team, like everybody, like from Brighter Bites, UT Physicians, UT School of Public Health, all the members of the team were meeting every week to discuss about how to implement it in a clinical setting, taking into consideration the challenges that would be anticipated and how to overcome those, and making sure it's smoothly implemented. And where we are here today, definitely it's a effort of the team all together. And thanks to the team.
Yeah. Thank you so much. And William, you get the last word on that for legacy.
Yes. And so just to repeat, the question is, how about delivery of food?
Just that, how easy was it to champion this within your health system, both with the providers and with the patients?
So I will answer twofold. The first fold was easy. We had site leadership engagement because we only still had one clinic. We had site leadership, we had providers on board. And so it just kind of folded in nicely. When we expanded earlier this year to 5 additional sites, it was kind of a challenge because people were already used to their workflow. They had not really utilized the like non-medical driver screening in their medical treatment. And so it really required some adjustments to how they conceptualize their role as providers. So, but many of them feel happy that they're making a direct impact to their patients.
Wonderful. Well, we are at time. Jackie,
yes, so I want to jump in here. We're coming up on the hour. We are at the hour. A quick reminder of our NMDOH program index that I talked about at the beginning. Please connect with me and you'll receive these slides following the presentation. Go to the link, click around, and when you're ready to submit, please send me an email at jk90@rice.edu. We'd love to get your programs showcased on this index as well. And then to the next slide, if you have a moment, we'd appreciate your feedback. We really want to tailor our content to the interests of our members. You are those members. So scan this QR code, click the link, and let us know what we can tailor our content to in the future. Thank you so much for joining us today. Everyone have a wonderful day.
Thank you. Bye-bye.
Thank you. Do presenters need to stay on or?
No, appreciate it, William. Thank you.
Okay, thank you.
Have a great day.
Bye.